what the priorities are. What matters? What are the actionable steps that I can take to the next call?
I think some people want to create content based off a single study and then try to pitch it as practice changing.
If your patients look very different from the patients in the study,
research and literature and evidence can be very challenging.
So we've talked a little bit about the different types and hierarchy of studies.
Everybody considers randomized controlled trials as the gold standard.
So is there a sweet spot in there? Should we be critical of the sample size?
I would say the main red flag is...
Welcome to EMS Cast, where...
Wait, Ross, what's our name?
Oh, that's right. We have big news. We are currently undergoing a restructure of the show. And with this is a new name and new logo that better represents our mission.
That's right. Over the next few months, we will be replacing our logo and the name you see in your audio apps, and it'll become Loud and Clear EMS Guiding Principles.
That's right. Loud and Clear EMS Guiding Principles. You see, we love to talk high-level education on this show. Our mission has always been to teach one step further than you learned in paramedic school. But we realize that at the end of the day, we also need to know what the priorities are. What matters? What are the actionable steps that I can take to the next call?
So every episode moving forward, as we dive deep into these advanced topics, we're going to make sure that we connect every discussion back to a set of guiding principles, so that at the end of the day, you will always know what's important in the back of the ambulance with the patient I have in front of me.
All right, enough admin. Let's get to it.
2 on 8. Okay, you're clear. Stand by for your base.
When I first started in EMS, it felt like everyone was immobilized on a long spine board. We learned all kinds of techniques to get someone on a backboard that were probably better suited for a game of Twister. Standing takedowns and KED usage. If the spider straps were in a tangled ball of Velcro, well, that was par for the course. Later, there started to be talk that maybe backboards don't actually help. Maybe they're actually hurting our patients. During this time, I heard about a study. In this study, 2 groups of patients were compared. Trauma patients in a large United States city that were put on backboards were compared to a group of patients from a developing country that were transported to the hospital without any spinal motion restriction at all. The number of spinal cord injuries was compared, and guess what? The patients in the developing country had less spinal cord injuries. I was sold. In my mind, we were doing harm with backboards. They're hurting people. We should stop using them right away. Armed with this knowledge, I felt like a rebel, ready to upend EMS dogma. Later, I reflected on all the flaws in the study, how many variables there are that can't be controlled, especially when trying to look at this information retrospectively. For starters, some developing countries have no EMS or robust trauma network. What about the availability of healthcare at all? What about how the population could self-select by their mere survival of the journey to the hospital? I then started seeing that this study, for what it was, really a Freakonomics-style comparison of apples and oranges, a study trying to woo me into a belief with correlation, almost like the medical literature version of clickbait. Well, this is kind of an extreme example, but how do we know if a study is legit? When do we trust a study? When do we change what we're doing because of what a study says? Lastly, when do we do something a certain way despite studies because maybe it's a hard thing to study in the first place? How do we answer these questions, especially now we have so much access to medical literature in seconds on our phone? Well, today we're going to be discussing this, so hang out with us. You may learn how to be a more discerning reader and clinician.
Welcome to EMS Cast, soon to be called Loud and Clear, where we talk about high-level education topics and connect them back to a set of EMS guiding principles. Today we have joining us Dr. Ben Lee. Dr. Ben Lee completed his residency in emergency medicine, and his final year was a chief resident, and then completed a clinical research fellowship with a Master's of Science in Clinical Science at the Denver Health Emergency Department. He's currently an attending at Denver Health. He's an assistant professor of emergency medicine at CU School of Medicine, and he leads the Denver Health Residency in Emergency Medicine evidence-based emergency medicine curriculum. He's also a reviewer for a journal, The Annals of Emergency Medicine. Before we get to today's episode and start chatting with Ben, I wanted to talk about your gear. You see, experts realize that logistics matter. And when it comes to your gear, how it is laid out, how it is set up, truly can affect patient outcomes. Our sponsor, the Recess Tailor's mission is to help you design bags that can better your patient outcomes. If you're unhappy with the current layout of your bag, if everything's just randomly shoved in there, reach out to the Recess Tailor. The contact page is in the show notes, and chat with him about if he can design a better bag for you and your system. All right, Ben, welcome to the show.
Thanks for having me. And I love that name, Loud and Clear.
Hey, thanks so much. We're really excited about it too. We also love the logo. I will share that with you.
Yeah, we're pumped.
So today we're going to be talking about evidence-based medicine. I don't know about Will, but when I went through paramedic school, and I think this is changing to some extent, but we got literally no education on how to review the literature, why the literature mattered, why evidence-based medicine was mattered. But it does, and it matters a lot. And I think we need this understanding as clinicians, as pre-hospital clinicians. So can you talk to us a little bit about what evidence-based medicine is and why it matters?
I think in leading our residency's evidence-based emergency medicine program, I understand that research and literature and evidence can be very challenging to get into, and it can at the same time feel like a very abstract concept as well as a very detailed and complex topic. And the barrier for entry can sometimes be too much and turn people off. But in my opinion, after doing my fellowship, I think that there is something for everybody out there, especially on topics that are most relevant to you as a clinician and your specialty, whether that's EMS in particular, emergency medicine. I think there's an idea that there is an ultimate objective truth. And the way to find that objective truth is through scientific inquiry that is objective and tries to do things systematically and remove all bias if possible.
I love that. Those were a lot of big words, and I think we're going to dive into a lot of those to help us understand all of that. But I really like kind of that approach to it. Now, when we approach the literature, before we dive deep into all these topics, can you give us maybe, three things, like when we're approaching a study, what are the most like the principles for how we should approach the study?
Yeah, absolutely. There are different approaches, and I would want to say that in general, there's no true right or wrong way. But I think the main principles are understanding the study design, and we'll talk about that a little bit as far as the hierarchy and certainty of evidence. And then also, how does this study apply to my practice environment and my patients? And lastly, how reproducible is this study and how valid are the results?
This is particularly challenging, I feel like, in EMS. Can you talk about why that's unique and a little bit of those challenges?
Yeah, EMS is really interesting for research. And I was reading a paper recently that looked at EMS research over the last 20 years, and there was like a 300% increase in the number of EMS publications, and there was a dramatic increase in the number of EMS grants for research that are available as well. But that is to say, it is a challenging setting to perform research because of the nature of pre-hospital work. It's hard to control all of the variables. Oftentimes, it's in the very emergent setting, and it's low resourced. And for all these reasons and others, it is hard to conduct what many would consider a traditionally high quality, rigorous study design, including randomization. And it's also hard to reproduce some of these studies. And as you guys know better than anybody, a lot of the different pre-hospital environments are very different with variable levels of resources. So one study that takes place in one setting certainly might not apply to your setting and your patients.
Yeah, that goes back to that second principle you talked about, like, does this apply to me? And I know the National Association of EMS Physicians is putting out a lot of position statements right now. I've worked on a few of them with the association, and it's challenging. They're putting a lot more focus on we shouldn't be taking in-hospital literature to inform our practice in the pre-hospital setting. At this point, a lot of it is all we have, and so you do the best with what you have, but we really need to put more focus on doing studies in the pre-hospital setting and trying to overcome those challenges. So I'd love to hear you read that paper that shows that there's a huge increase, because that's great, because the position papers I worked on was a lot of there's no evidence right now, at least in the pre-hospital setting, for whether or not we should be doing these things.
Absolutely. I also feel like one of the challenges is that with all the emergency medicine and trauma research that's done, high quality or not, it's still very challenging to generalize those results and those practices to the pre-hospital setting, given all the differences in the resources.
So, Dr. Lee, I have a question. So, let's say, I'm a paramedic and I run a call, and after the call, I'm thinking, I wonder if that treatment even works, or why am I doing it this way? So I go on PubMed and I type something in. When I get a study, what's my approach? How do you approach a study when you first start digging in?
Yeah, I think even before that, like what you talked about is importance of finding something that is relevant to you. And so it's hard to just go on PubMed and search something up, or pick up a physical journal and start just perusing the pages to try to find something that interests you. So I oftentimes tell our residents to start with a case, a patient that you remember and can visualize, and then start asking the questions like, is there evidence for these interventions that we performed? And then go to PubMed or to other resources like UpToDate or using FOAMed, and explore that question further.
And then once you find a paper that explores that question, or say you just come across a paper that catches your eye, how do you approach that individual paper? Like, do you just start from the first word, first paragraph, and then read it all the way through, or do you have a different systematic approach to it?
Ross, I think I knew you go to the abstract and jump to the conclusion, right?
There it is.
Yeah.
Hey, that's not wrong. That's not wrong. I mean, at least you took the first step and did a little bit of exploration, which I think is an underrated thing, and that it can be really intimidating and can stop you from even beginning the process of looking things up. But if you can just take that first step and find a paper and maybe just look at the conclusion of an abstract, I mean, that can pique your curiosity and compel you to read a little bit further. But there's no right or wrong way to go through a paper, as long as you read through it systematically and have a process. And so me personally, I like to read it from the beginning to end. So starting with the abstract, kind of get a high level view of all the different components, and then just start reading the paper, because I feel like the introduction and background can offer a lot of context for why they're doing the study and what the questions are that haven't been asked, and kind of what the gap areas are, because that provides some degree of like, how meaningful is this in the general context of whatever topic it may be. And then just move through it after that, look at the methods, look at the result, and then the discussion. Sometimes when I am performing reviews, I will start with the methods, because the methods can be particularly dense and hard to get through. I know it's going to take a lot of time, and maybe I'm not going to know all of the methods that they use. So I know I'm going to have to spend some time looking those up. And but in general, again, I feel like especially if it's something that is not as familiar to me, starting with the introduction and the background can give you just a lot of context about why they're doing the study.
Can you, Dr. Lee, go into, speaking of like study design and methods, like you start to hear words like prospective, retrospective, randomized controlled trial. Can you kind of go through, I guess, is there a hierarchy to these study designs, and what should we be looking for, or is it not that simple?
No, it's generally simple, and I think there is a hierarchy of study design. I think that you have to take it with a little bit of a grain of salt, but in general, you can look these up, and for the most part, they're the same, and that they show a pyramid, and at the top of the pyramid are systematic reviews and meta-analyses, because those take all of the primary or individual studies and look at them in a systematic manner to draw conclusions. And then kind of below that is the randomized controlled trial. And again, the hierarchy is based on, this idea that there is kind of an objective scientific truth and you're trying to find the answer. And sometimes that involves causality, because that's very important in many different types of studies. And then below randomized controlled trials are your cohort studies. They can be prospective, retrospective, and then your case control studies, and then your cross-sectional studies, and then kind of case series and case studies, which are just individual patients and cases that sometimes can seem anecdotal. And so the further up you go in the hierarchy, the more kind of systematic the studies become, and the more causal they can infer, and then the more they can control for bias, which is an important thing to consider, because you want to make sure that, again, it's as objective as possible and accounting for all the potential biases, of which there are numerous, and also accounting for chance, and that the results of this study are not just because of chance. So despite this hierarchy, when I was talking about taking things with a grain of salt, is that everybody considers randomized controlled trials as the gold standard, in that it can account for known and unknown biases and confounders, and can establish causality, and is the most rigorous study design. But there are many, many instances where randomized controlled trials, for different reasons, may not apply. And from a logistical standpoint, from an ethical standpoint, there are some studies that are not possible to do in a randomized controlled way. And understanding that is really important as well. So not to just say, oh, it's not an RCT, it's a retrospective cohort study, that evidence is not as good, I'm not going to read this. It's good to understand kind of the strengths and limitations of each study design.
Yeah. And so the term randomized controlled trial, right, just means that we're randomizing patients. We're not choosing which group they're going into. And then along with that comes the blinding. So hopefully it's you may hear the term double blinded, which essentially means that the person receiving the treatment doesn't know which treatment they're getting, and the person giving the treatment or studying the treatment doesn't know which treatment the patient got, which can help remove that bias like you talked about. You also mentioned the term causality a couple of times, or causal. Can you talk to me about the importance of that term and why we're trying to get at that versus something else?
Yeah, I think causality is important because it can establish, quote unquote, fact that one thing may lead to another. And we want to know that because that can tell us how to intervene and how to prevent or intervene on whatever causal factor it was to prevent the outcome, versus association or correlation, where depending on the study design or the type of statistical analysis, you may not be able to tell that one thing causes another. So you're trying to draw associations between one thing and another. And again, randomized controlled trials may not apply to every type of study and question that you're asking. And so the next best thing is trying to establish correlation and association. Basically, correlation and association are the next best thing to causation.
That's kind of the best you're going to get in that situation, huh?
Exactly.
So is it everything less than randomized controlled trial, then we're essentially not going to be able to show causation, and at best we're going to say these two things were associated or correlated with one another?
Some may say that. There are, say, like high quality prospective cohort study can, with a high degree of association, can come close to telling you that there's causation if they did a good job for controlling for confounders and bias and those types of things.
I want to get into a few terms. And so this gets into what you just said. I think gets into a little bit of the certainty of evidence and how well done a certain trial was. So we talked about what a randomized controlled trial is. Let's talk about some terms now. What's a cohort study? And what is prospective and retrospective?
Yeah, a cohort study is where you take a group or a cohort of patients that have a known exposure, and you compare them with a similar group of individuals or patients that do not have that exposure, and then you follow them in time And again, this can be prospective, so it can start from now, and then we're going to continue on into the future and see what outcomes or diseases these people might develop. Again, one group being exposed to a certain thing, and then the other group not being exposed to it. Or you can look back in time and see kind of the similar thing. So looking back at one group was exposed to something, a similar group was not exposed to something, and then follow them in time to say present and see what, again, diseases or outcomes that they developed during that period of time.
And so prospective being higher in the hierarchy than retrospective, because if you start from now into the future, you can better control and plan for some of these biases and confounders. So tell me, I think most people at this point know what a bias is. Tell me what confounders are.
Yeah, confounders are things that, again, some are known and some are unknown, but they are variables or factors that can impact the relationship between the exposure and the outcome. So a classic example is like, you do a study to see if drinking coffee causes heart disease. And you do the study and you're like, oh, it has this really strong relationship or correlation with, the more coffee you drink, the more heart disease you develop. But then you realize that a lot of the people that drank coffee were also smoking cigarettes, and you didn't really take that into account at first. And so it can modify or can confound or cloud the relationship and affect the relationship between the exposure and the outcome.
And there are ways to, attempt to control for that too via statistical modeling, where you compare just the smokers and coffee drinkers to just the smokers and non-coffee drinkers, and then non-smokers and coffee drinkers, non-smokers, non-coffee drinkers. But those are never totally perfect.
Yeah, they're never, for a cohort study or a case control study, they can never really be perfect. Again, prospectively, the advantage is that if you know what the potential confounders or other variables that may cloud the relationship are, then you can control for that. And you can say, oh, well, I don't want to include any smokers in my study. Or after you do the study and are doing the analysis, oh, I'm going to stratify the results and look at the people that smoked or not smoked, and to see if that is impacting the relationship between, in this example, coffee drinking and heart disease.
Yeah, and I see a link with this to something you were talking about earlier, this idea of a confounder or these variables being very relevant to how we design studies for EMS, because we have a lot of confounders, our response time, our scene time, and then even with that, you could have a patient on the same street corner, equidistant to the same hospital, but then traffic might be a confounding aspect. So I think to all EMS providers out there, being curious about research, and if you're interested in it, getting into it is incredibly helpful, because our perspective is incredibly valuable when designing studies that are going to impact our care.
Yeah, and I think speaking to the strength of the randomized controlled trial is that for the most part, we know what we know, and oftentimes we don't know what we don't know. And so you may know what most of the potential confounding variables and biases are, but there are probably some that exist that you may not have thought about. And sometimes at the end of a study, that's called residual confounding. But in a randomized controlled trial, you are randomizing patients to one arm an intervention and the other arm a control for the known and known confounders and biases in kind of the most rigorous way.
So we've talked a little bit about the different types and hierarchy of studies, and the more robust and more well-performed the study is, it's going to give us a higher certainty of that evidence. Are there any big do's or don'ts that we should be on the lookout for in any of these studies?
Depends on the study design, but I would say in general, when you are looking at a paper, you just want to make sure that they clearly described their methods and their study design and their patient population and their setting. I would say the main red flag is when you read a study and any of these aspects are unclear or not well described.
Can you talk briefly about sample size? To be more specific, my a rudimentary understanding may say the larger the sample size, the better. With some things we want to look at, there's just not a lot of patients out there to study, or once we control for variables or confounders, maybe our sample size goes down. So is there a sweet spot in there? Should we be critical of the sample size?
Yeah, sample size is really important. And like you said, depending on what the study is, if it is a very rare exposure or a very rare outcome or disease, then that can affect what type of study you perform in the study design, whether that's a cohort study or a case control study. It speaks to this concept of statistical power. And power is important and incorporates the sample size and kind of like your tolerance for error in trying to determine, do you have the adequate number of patients in your study where if there is a true effect, you measure it. Because if you only have 2 people in a study, then there's a high probability that whatever you measure could just be due to chance. And so taking into account the sample size is really important in knowing, did they have enough patients to measure an effect if there was a true effect going on. But conversely, you can overpower a study if you have too many patients, because the more patients that you have, the more likely it is statistically to find some type of difference, but that difference may be minute and ultimately not meaningful, especially in the clinical setting.
I learned in college, my college statistics class, that 30 was a magic number. Is that true in stats and in sample size?
No, 30 is definitely not a magic number, but it really just depends on, again, like what the outcome is. Prevalence comes into play, like how prevalent is the disease, but sample size is important. Again, speaking of power, because yes, you want to determine if there is an effect. Do I have enough patients to measure it? And does this have clinical relevance? Because statistically, there might be a difference or significance. Say the P is, less than 0.05, but translating that to the clinical arena, does that actually make a difference in patients' lives and outcomes at the bedside?
So we've set this, you just mentioned the statistical significance at this artificial value of like this P value of 0.05. Can you quickly talk to us about what that is, what that means? And then also when we were talking about sample size, that gets a little bit into confidence intervals, which you'll see in the paper often, various papers. Can you talk about that a little bit as well?
The p-value is the kind of like most known traditional statistical measure of significance. And some journals that are actually moving away from including the p-value because, again, it may tell you from a statistical standpoint that something is quote unquote significant, but is that actually significant in the clinical setting? And so sometimes when you're speaking of confidence intervals, a confidence interval may offer you a little bit more nuanced information about the significance and the clinical significance that is more relevant in the kind of emergent clinical setting when there's somebody really sick in front of you that you have to do something about.
So what does a p-value mean of 0.05?
Oh man, this is a really, there are videos of like physical conferences. I don't know if you've seen this, where somebody just goes up with a microphone and is like asking all these biostatisticians what the p-value is, and like none of them can answer it.
Give it.
Yes. It's like,
is there a p-value that would be like alarmingly bad if we were looking at a study?
Well, I guess I want to just get at the point that it's, and maybe I don't have an understanding of it, but I will say this. One of my favorite quotes is from Nick Matzler, and he says, "The process of teaching science is just telling smaller and smaller lies. So I kind of just wanted to get at the idea that it's like, what are the chances that our finding is due to chance or due to random chance sort of thing?
That's basically what a p-value is, and it's our degree of tolerance for chance or error. And so the 0.05, it's kind of the other side of it. It's like we would like to be 95% certain, but again, whether that makes a clinical difference or not is a question that we have to interpret.
Fair enough. And then the confidence intervals, am I correct? And they're kind of like, we got this single number, but that number really could range from here to there based on our sample size.
Exactly. Yeah. And confidence interval is also notoriously difficult to state a clear definition. But essentially, yeah, if you repeated the same study over and over again, then basically what is the the confidence interval is the percent, like 95% confidence interval is kind of the most common measure that people use, that the value will fall in that range. So if it's really narrow, then that's probably a good thing. Where if you just repeated this study many, many times, then the value that you achieved is likely going to be more accurate or reliable. Versus if the confidence interval is really wide, then it's harder to say with repeating the study if these results are going to hold true.
And it's usually measured in like a percentage or often represented as a decimal point. And so we're looking for if that confidence interval crosses 1, then essentially there's a chance that there could be no difference.
That's correct. Yes.
Okay. We've gone through a lot of terms, a lot of hierarchy and study designs. Now let's get to we want to apply this. How do we start to apply the paper and determine, can I apply the paper to where I work in my patient population?
Generalizability of the results of this study to your patient and your setting. And so for that, I typically look in the method section in the study population and the setting and see, what were the patient demographics? Are they similar or different from where I work, my patients? And what is the setting and kind of what resources did they have available to them? And does that apply to my setting as well? And there's a lot of nuance to that, but from a general standpoint, reading that section can give you a general clue about how well it might apply to your patients.
Yeah. So in other words, if your patients look very different from the patients in the study, be it age, comorbidities, sex, whatever, or your practice setting looks very different than what was in the study, say you have a 30-minute transport versus a 5-minute transport, then the results they found, if they were to do the study in your specific setting, may not hold up.
Yeah, they may not hold up. It doesn't mean that they won't for certain, but it just means that there's not enough evidence to prove that it would definitely apply. But oftentimes, just the nature of research is, you begin a project that just due to your own resources has to take place locally with your population, and then based on that study, if you find some results that are interesting, you then can start trying to do, multi-centered trials in other settings to see if there's external validity to your results, and to see if they generalize to other populations and settings that may be different from where the original study took place.
I think this segues nicely into reproducibility. Why is it important to have multiple studies on a single thing rather than relying on a single study?
Yeah, I think that speaks to this idea of trying to alleviate chance and bias in the results. And so being able to reproduce a study, whether that's internally in the exact same setting that the first study took place, or externally in a different setting, is just really important in establishing a consistency and increased validity for the results that you achieved, as they are less likely to be due to chance if you can repeat it and get similar results.
Are there Any red flags to look out for when reading literature? One of the ones you talked about was not clearly describing your methods section. Are there kind of anything else to look out for?
You can learn something from any study, whether it's how to conduct a high quality study and write it up, or how not to. And so I think reading studies that maybe have flaws is better than not reading at all, because your curiosity is triggered and that might lead you to go further, read more, ask more questions. And then it may be kind of silly to mention, but also it's important just to understand what scientific research is and respecting the peer review process.
I kind of love that encouragement that you're giving right now. I think, literature can be so overwhelming. It still is to me. I mean, when you start breaking down stats and you have difficulty explaining what a p-value means, and then you get into more of the complicated stats, it can feel intimidating. So I love this idea of like, hey, you don't have to be perfect at this. Just start doing something. Start piquing your curiosity, and the more you do it, the more you're going to get better at it. So you don't have to be perfect at reading a study from the get-go. Just start reading something.
Exactly.
Where should we go to find literature to read?
Finding a source that can curate, because there's just so much out there that is published every single day that, again, that's another factor that can be very prohibitive in just beginning to read. And so finding a resource that filters the most relevant literature in whatever area that you are interested in, whether that's EMS or emergency medicine or trauma. And some of those things are like MRAP's emergency medicine abstracts. They do a really nice job. Up to Date has a section where they provide the most recent literature from like the past month in certain areas like emergency medicine. Another one that residents really like is Journal Feed, and that you get a daily email about a relevant study that was done in different specialties like emergency medicine. So those are the main ones.
The main thing that I would say is FOAMed related for some of this, I think specific to EMS folks, is I think some people want to create content based off a single study and then try to pitch it as practice changing. And that's you have to be very careful and skeptical of that type of stuff.
Yeah, one of the ones that I like is the Skeptic's Guide to Emergency Medicine podcast. I think they do a nice job critically appraising the literature.
Perfect. Well, this was a deep conversation with a lot of big words, as I said. Hopefully we helped define some of those for you guys so that this can be a little less intimidating. But like we've talked about, just go out there and read something. Learn what one stat means every time you read a paper. And, over the next year or so, you're going to know a whole heck of a lot. So Ben, to wrap this up, kind of summarize for us, how do you approach and critically appraise literature?
You got to have a system. And this is something that you don't have to necessarily figure out on your own. There are a lot of templates out there for critical appraisal for different types of study designs, because depending on the study design, there are many different questions that need to be asked about how well the study was done. And there are some free resources, and I can provide some links for those that provide you basically checklists about how to systematically appraise and examine a study, asking questions like, how are the methods and things to consider. And it just provides a really nice framework to go through papers and figure out what are the types of questions that need to be asked when you are reading or appraising a paper. And the more practice you get with that, the easier it will become, and the more informed you will be, and really the better that you'll be able to appraise literature on your own and draw your own conclusions about how it's going to affect your practice.
I love that. Yeah, we'll definitely include those links to those resources in the show notes under the resource section. And I'm going to start using those in my own practice when I'm reading literature, because I love that. Definitely help you learn and make it much more approachable and simple if you have a checklist as you're going through these. So thanks for that, Ben. All right, let's wrap this up. So what would you want the 3 biggest take homes to be for people after this, after listening to this podcast?
The number one take-home point for me would just be to make it relevant to you individually and for your practice, because the vast majority of pre-hospital providers and EM residents are going to go into careers in research. So really, I think it's important to just start from a place of personal relevance, a case you had or a question you had specifically, and to just ask why and begin the process from there in your literature search. And then take home point number 2 for me would be to really determine if the study is applicable to your patients and translates to the clinical arena, because if it doesn't apply to the sick person you had in front of you that needs intervention, then what's the point? And then my third take home would be to have a system for reviewing papers and appraising the literature. And again, there are many models and frameworks for this that are free that we'll provide links to.
Thanks so much for all of this, Ben. And to our listeners, if you found this useful and you have any further questions and want to dive deeper, please reach out to us, email us at ross@emspodcast.com or will@emspodcast.com, and we'd love to cover this some more if you have more questions.